everyone. I'm Mariah Janowski. I am a PGY4 general surgery resident here in Phoenix at Creighton University. I have had the privilege of rotating with Dr. Ramaiah for the last month, and so we came across this case just within the last week, an interesting case that we wanted to share. The patient is a 72-year-old female. She has a past medical history notable for hypertension, polycythemia vera, Raynaud's disease, as well as a remote history of breast cancer. She's also had a history of TIAs, COPD, previous splenectomy, and she's also had bilateral saphenous vein ablations. She was initially seen for claudication symptoms of the left lower extremity back in 2019 by another vascular surgeon, and she was treated conservatively at that time. In April of 2020, she developed sudden onset severe left lower extremity pain and some bluish discoloration of her left foot and toes consistent with ischemia. And at that time, Dr. Ramaiah performed a left lower extremity angiogram with HOC1 atherectomy of the SFA and popliteal arteries, and as well as impact DCB of the entire SFA. And these are just some still shots of the angiogram from that time. You can see there's a flush occlusion of the SFA on that image on the left of the screen, and then just the distally on the right. And these are after the atherectomy and DCB. You can see the runoff. Notably, in May of that same year, she had developed ischemia again and had stents placed at that time. Again, in December of 2020, later that year, she presented with left lower extremity ischemia and a cold leg. And at that time, the SFA stents were completely occluded, which I'll show you on the next slide. She underwent JEDI thrombectomy, impact DCB angioplasty, and also balloon angioplasty of the TPT and posterior tibial with a nanocross balloon. And so these are the images from that time. You can see the complete occlusion of that SFA stent. And then on the image on the right, you can see this is after revascularization. And again, this is the runoff. Notably, just a few weeks after that, in later of December of 2020, the patient developed severe sepsis. She was found to have feculent peritonitis, secondary to perforated diverticulitis and ischemic bowel. She underwent a Hartmann's procedure and had multiple CT-guided abscess drainages. She had quite a prolonged hospital course, and in the patient's own words, she almost died. She has had many episodes, medical episodes that have precluded her from open procedures, which we'll talk about a little bit later. She's very tenuous. Over the last 5-6 years, she underwent yearly duplex ultrasounds, all of which were fairly unremarkable. She didn't have any aneurysm, and her ABIs were normal. In 2024, as well as 2025, she did have tiny fluid collections, like a centimeter, sub-centimeter around that left SFA, but otherwise unremarkable. Fast forward to just this past week, on February 23rd, the patient presented to an outside hospital. She had progressive nausea, poor PO intake, which she says she didn't have any teeth. She's been waiting for dental implants. She's had a ton of weight loss and fatigue. And she also mentioned that 2 days prior, she also felt like maybe she might have hurt her left leg. She had some swelling and some pain, and she thought it was a pulled muscle. She did not have any fevers or chills at the time. She had just a mild leukocytosis with a white blood cell count of 13, which could have also been secondary to her E. coli UTI. She did not have any erythema and no cellulitis of that leg. She did undergo CT scan, which I'm going to show you here. And if you just look closely around that left SFA when it comes up. Pulled muscle, right. And then this is just the coronal view. So you can see that large, it was like 8 or 9 centimeter fluid collection around the SFA, concerning for pseudoaneurysm. We had her promptly transferred to Honor Health Osborne for vascular intervention. And at this point, we were kind of thinking, what could have caused this? I mean, it's been 5.5 years since her last endovascular procedure, and her interval duplex scans have been fairly normal besides the tiny fluid collections the last 2 years. And we were kind of thinking, how do we treat this? Do we need to do a bypass? Is this infected? Do we have to explant the stents that she has? Because of her medical history that I've touched upon, we opted to at least start with an endovascular approach and see what we found. And so here are...
Can I ask you a quick question?
Sure.
I know you're going to go there, and maybe we should ask the questions at the end, but I think it's sort of an important ask. I mean, I would have maybe got like a PET scan if she's not emergent, mainly because it can tell me the extent. I know it's infected, but I
Right.
want to know the extent of the infection. So is every stent all the way up, lighting up, bright red, or is it just that one little focal thing? But
Right.
that's the only thing I might have done differently. If it's emergent, she's dying, then just do what you're going to do.
Yeah, it's definitely an interesting point. It kind of didn't come up, and we didn't know for sure if it was infected, especially because she
It's
wasn't...
infected.
That is infected. Let's
I don't know.
How about the fever cultures, blood cultures, anything positive?
No, and I'll get there. Just the urine was positive, but she didn't have fevers, no chills, no cellulitis, no erythema. Her blood cultures were negative, and I'll get to the cultures later on as well.
I thought she had E.
That's a
coli.
Viabon there in there?
Yes.
Yeah, she is infected, weight loss, all the stuff.
She's also not eating.
Yeah.
She doesn't have teeth. Yeah.
Huge mass sitting in the leg and complaining of pain. So we took the chance and lined it. I mean, I can always, take it off if all the cultures come negative.
So here are her CT scans, we show the CTs. This is from our angio, and so we gained access on the right and went up and over. And then you can see here a large pseudoaneurysm here. And you can see the you can see the mass effect from the hematoma there as well.
This had gotten Hawk in the past,
Yes.
and what stents were put in there? Were they drug-eluting, alluvia, just normal
First one, I
stents?
think in 2020 was an atherectomy with the HOC1 and a DCB.
And then,
And then stents were put in later on in May.
Mm-hmm.
And then she came to us in December, all the stents occluded. So we did rotational, jedi, thrombectomy. We lost her for 5 years almost, even though she would come for follow-up. But no complaints.
yep. And so here's some of the more angiograms. That's just distally, I don't know why that one played first. And then here is kind of the interesting one, and this was sort of how we came up with the diverticulitis of an artery, because it looks like she has this outpouching from
That's infected.
where the stent is, and obviously the large contrast blush. And so we performed IVUS with our angiogram, and this allowed us to kind of measure and figure out the size stents that we needed. And we decided to coat the injured segment with Viabond. We used a 6 millimeter distally and a 7 millimeter proximally, and they had excellent overlap. I'll show you the images, as well as.
Just a question for Dr. Ramaiah. It's a little short outpouching, but you got two 250s. So was the plan just to recover everything?
Because, go to the one when you put the first one in,
That was the last one, right?
go to the previous one.
Yeah.
If you see that artery, I mean, first thing was like, yeah, this is, I think, totally infected, of course. But you see those little outpouchings? Diverticular of the artery.
No, I mean,
It's a destroyed artery because of infection, buddy.
yeah, I mean, so it's
So
an injury
why
to the
didn't you
fabric
P-tab it
and
then?
It's like,
Go ahead.
Yeah,
It's a very interesting case.
Yeah,
She also had vein ablation.
I share Frank's concern of, now if you're dealing with an infected site, which we assume it is, suddenly you put a lot more PTFE and foreign body in there rather than bypassing around or
Yeah,
something
but
like
I
that.
can show you the elective. You see, when she came in emergency with the bleeding and everything, we had control of that. I can always take out the ligate and take out the graft and go on and do a bypass, whatever.
She also really needs to be medically optimized before she undergoes such like a large open surgery as well.
I thought she was totally healthy. No fever, no malaise, none of these.
Yep.
Go ahead. I'm just teasing.
So these are some of the imaging here after our intervention. You can see no more diverticulosis of the artery.
Oh, you fixed that.
diverticulums have disappeared.
And this is after the stenting proximally and distally. And this is just her runoff. And then the second image here, this is a run that we took after we performed evacuation of the hematoma. You can see we left a drain, and you can see here how that segment really straightened out compared to what it was previously with that mass effect. And here's some images of the hematoma. This really doesn't do it justice. It was a ton in there. But just to highlight kind of what we were seeing, and you could see that sort of sac around as well. There was no purulence at all, and it really wasn't super friable either. And so what happened? Obviously, I think initially we're all thinking infectious. That's what we were thinking initially as well. But again, she was systemically not sick. She didn't have any signs of sepsis, no fevers, no chills. Again, on her physical exam, she didn't have any erythema, cellulitis. She did have blood cultures that were negative, and we took cultures in the operating room as well, which have all since come back negative completely. Anaerobic, aerobic, fungal, AFB, all negative. So then we thought maybe there was a trauma, especially because it's been years since her last intervention, but there was no evidence of stent fractures. And here you can see, we just kind of took a little bit of closer up pictures of the stents, and we don't see any fractures of the stents.
The only question I would have for you, and I don't know the answer, but it's just sort of hypothetical maybe, is some of the drug-eluting stents can cause sort of late-term pseudoaneurysms or aneurysmal degeneration. There's one where the reports are a little bit higher. I still use them. And I almost wonder if maybe the combination of your HAWK and the DCB cause like these little pseudoaneurysms very, very late term. I mean, that's the only thing I can think about if it's not any evidence of infection. And Craig, I'm sure you've got a lot more data and information on some of the stents causing some aneurysmal degeneration.
Yeah, we have seen some of that. Never like this, though.
Yeah.
I've never seen an artery look like that.
So you got no cultures, you got no organism. Just tell us, did you put her on antibiotics and for how long and what antibiotics?
Disease concept.
What did they do? Because they're probably going to ask you, wow, what do we do? Yeah.
I'd get a PET scan. I'd get a PET
Now
scan.
it's gonna be,
Now, I can still get a PET scan.
Yeah,
Well, the PET scan early on is probably going to be false positive.
Yeah, it's gonna
Yeah.
light up.
You have to wait a little while. And
this is silent.
the time frame that actually turns not false positive, nobody knows.
right, right.
Now, obviously, the first thing you think of is infection. Second thing is, since all our cultures, like, and she was like, oh, I thought it was my muscle, she was not even like, red.
Infectious, it's very interesting.
So when we took a immediately PO or after I cancer, we saw this, we did an angiogram, we saw the CAT scan. So I said, from that time, I can always take this out. Get rid of the bleeding and the trauma, and we put the live one. But my take is, did atherectomy and PCD cause this?
Yeah.
And I've seen a lot of pseudo using with atherectomy, especially the Hawk device, over the years, like this, bulbous, but
Yeah.
nothing like
Multiple
So-
small holes.
small, bubbles.
Yeah.
But you did the atherectomy, and then months later, you put stents in. So it wasn't, they should have healed from the atherectomy.
Between the atherectomy and the original stents, it was less than a month,
Oh, okay.
I believe.
So that's my take. I think atherectomy caused it.
It's our take.
And maybe infection is propagated it.
Yeah.
The question then is, when will you take this out or when will you bypass it?
Well, the problem is,
Just take a watch.
I think I would personally watch it until she manifests as a sepsis. Although the way she presented the patient, she sort of sounded like she had malaise and all these other things. The problem is she's had both saphenous veins ablated. So then you got to get to like, how are you going to reconstruct it? I'm sure someone around here would say, just take arm vein but most of these patients, she's been in the hospital with diverticulitis, Hartman's.
When was the last time you did an arm vein bypass?
10 years ago.
She also has very poor venous access
Yeah.
to the point that she has a portacath.
Yeah, there is a new product out that I have used some in situations like this. Is no option she's not CLI, but no option, and that would be the humacyte graft. So
That's already out of market, isn't it? FDA
no, they put a warning on it to not use in the abdomen, but it's actually still approved. I know because I just used it the other day, and there's no black box. I mean, it hasn't been pulled, but it's still, and they just had some very good results published at the VEST. So,
The only other thing is cryovein.
yeah, I
I
just think
don't like, but-
cryovein is terrible.
Femoral artery is the other one that is,
Yeah,
I look at you-
I don't like
Work
cryovein,
recently,
but
though?
yes, you could use that as well.
I look
No,
at this way, what
not
she said,
recently.
she almost died of diverticulitis. So say
Yes.
systemic sepsis,
Yeah.
it landed up in the foreign body, over a period of time, bacteria eat that portion out, you became like that, and then it leaked. Because she has been suppressed with
Antibiotics.
antibiotics, she had Hartman's procedure. 6 weeks of antibiotic has suppressed everything.
Yeah.
Can I ask something? Dr. Neville reports a lot that he uses synthetic with a very distal area vein cuff, and that he's had nice results with that.
Yeah, that would be great, but if it was infected, you get concerned that the PTFE is gonna get infected.
Okay,
Yeah.
that's, I was trying to understand why.
I would leave her alone for a while.
Yeah.
Like,
Yeah.
I agree with you, leave her antibiotic, give her antibiotic. Follow
Make
her
her
up, see
force
what
you to
happens.
operate on.
Yeah, you can always operate.
Yeah, we'll come back next year and let you know what happens.
I'd ride that horse till it starved and dropped.
Thank you.
Very, very nice. Thank you.
Thank you.